Well, I would like to welcome everybody to today's Grand Rounds talk. I see 50 people in the attendee list, so I will declare that as a quorum. It's my pleasure to introduce Dr. Brian Dixon, who many of you know and are working with or have worked with. Brian is a faculty member in the Fairbanks School of Public Health. He is obviously a long-term Regenstrief investigator, and he directs the Public and Population Health Informatics training program. Typically in these introductions, I try to tell people something that they may not know as well about people or appreciate as well. So one thing that I really appreciated by Brian is his commitment to mentorship in a variety of levels. He's actually gotten awards for mentorship at the collegiate and high school level. And we went together through mentor training. So we both kind of could bond over a shared appreciation of mentorship. And as we all know, mentorship is really important to all what we do. Before I let Brian take the floor, I am also asking everybody to cross their fingers, because Brian and I, as well as our close collaborating team, were putting the finishing touches on the T15 renewal application, which is going in 2 days. And so please send good vibes for the application. It is the renewal for the application that Brian and I actually got again for Regenstrief 5 years ago. And it funds our Indiana Public and Population Health Informatics training program. With that, let's turn to the main event and let Brian tell us about responding to the COVID-19 pandemic saga of the Public Health Informatics program. Take it away, Brian.
All right, thanks, Titus, for the warm introduction. And yes, we welcome all good vibes as we look to renew our training program here for the next 5 years. So what I'm going to do is I'm going to try to tell you a story and then leave some time at the end for some questions. But the story is really around our public health informatics program at the Regenstrief Institute and the saga that it's been through over the last year. So briefly, a little bit about our program. We launched our program in October of 2018, and there's really 3 sets of focus for the program. The first is around supporting what I call the business of public health. So that is all the core functions that public health does, everything from restaurant inspections to disease surveillance to engaging in community, working with community groups to address health problems. So all of those activities are in the domain, the business of public health, and we aim to support those through information and information technology. The second thing that we try to do is we try to assess and improve the health of populations. So Regenstrief globally tries to improve health and well-being. We focus on addressing health and well-being through assessment, because you can't improve what you don't measure. And so we want to try to improve things like vaccination rates. So pre-COVID vaccine, we still wanted to improve vaccination rates, and we want to do things like reduce obesity in our population. And the third thing is, and hence the training grant that's going in this week, is we want to educate and train the next generation of scholars. So we're particularly focused around those scholars intersection of public and population health with information technology, but also training others in biomedical informatics writ large at the Center for Biomedical Informatics. So these are our goals that we launched with. We have a number of folks, so it's not just me, it's not the Brian program, it's the Regenstrief and Fairbanks School Public Health Informatics program that involves faculty from the Center for Biomedical Informatics, faculty from the Center for Health Services Research, faculty from the School of Public Health. Even if they don't claim to be informaticians, we still try to engage people from that unit. It involves collaborators from the State Department of Health, the Marion County Health Department, FSSA. So all folks who are interested in data and information as it's used and can be used to improve health and well-being. Trainees. Our trainees are, we have our NLM program that Titus mentioned. We also have informatics fellows beyond that that are based within the program. Dr. Nimish Valvi is our current trainee. Before Nimish was a fellow here, we had Dr. Sarab Raharkar, who's now at Ohio State University. And we also have two wonderful supporting staff, Jess and Ashley, who you know, basically they tell me where to go and what to do these days, and that's wonderful because there's a lot going on, as you'll see, and they keep me from losing my sanity. Hopefully they've kept theirs. So we also have a number of partners. So our work is done in partnership with health systems, with public health agencies. We can't do this work alone. So all the things that I'll be talking about today really have been done with our partners, and we need our partners to do our work, and we want our research to be translated into practice. That's one of our key missions, is to not just develop informatics for the sake of developing informatics, but have it be used to guide public health decision-making and population health interventions in the community. Okay, so let me get to the story, and that is that our program was only 14 months old when COVID hit. So on the one hand, you could say, well, we had the foresight to build a program that could be responsive to COVID well in advance of the pandemic. On the other hand, it still took us surprise, just like it did the rest of the world. So when COVID hit, particularly in the US, our program was really just in the early phases of getting off the ground and getting organized. However, we felt very strongly, as did many others in the Institute and on campus, that we needed respond to the COVID-19 pandemic in some way, that we needed to step up and do something. And so with support from Dr. Emby and especially Dean Halverson of the School of Public Health, our program really got engaged in a number of ways in responding to the crisis here in Indiana. So most of our work is focused on Indiana, but where we can, we want to translate and disseminate our lessons to others, both in the US and around the world. So there were really two pillars to our pandemic response, two kind of sets of activities that we were engaged in that align very closely with our overall goals in the program. So the first pillar is to strengthen our public health system in Indiana and in the US largely. So doing things like epidemiology, disease surveillance, supporting those functions, right? Core functions of public health, along with supporting the activities of like contact tracing that are so important in an outbreak situation, quarantine, giving information that can help guide those types of decisions that public health agencies need to make, and the information they need to do those functions. And then of course, eventually, prevention of the disease. In the beginning of this disease, we didn't have vaccines, now we do. So a lot of our work has transitioned to vaccination related activities, but in the beginning, it was about, mitigation of COVID-19 in communities. The other pillar of our strategy was really around strengthening health systems. So our other partners are the health systems and hospitals that are essentially, triaging and getting these sick patients and taking care of them, but they're also very concerned about the population health in their community. They needed to be prepared for what was going to come. They needed to manage their resources, and also our biotechnology, or I should say biopharma companies also were in the process of working with health systems to develop therapeutics, and they needed information and data on what was happening at the population level. So all of these components of our healthcare system are critically important, regularly for our research, but particularly important, they all needed to be addressed during the pandemic. And so our team has really worked hard this last year to support both of these pillars as we navigated the pandemic together with our partners. All right, so if we go back a year to March of 2020, we were all dreaming of, the next big event here in Indianapolis. We all were looking forward to, being in crowded spaces with strangers and sharing germs with them at events like the Indy 500, right? And thinking about that because we were getting close to the month of May, couple months away, but still thinking about it, as we always do in Indianapolis, when lo and behold, we have our first case of COVID-19. This actually happened just a couple days before I was supposed to leave for the annual Health Information Management Systems Society, or HIMSS, annual conference. I was looking forward to going down to Florida, presenting at the conference, and of course, 2 or 3 days before the conference, we have our first case, and then the next day they cancel the event, right? So we got very used to cancel culture because everything was canceled because of COVID-19. And so because a lot of our normal activities were being put on hold because of COVID, our team pivoted to start working on COVID-related work. So one of the first things that we did is that we drew on our experiences of taking data, moving data from the healthcare system to public health for notifiable diseases. So we move data all the time for sexually transmitted infections, for tuberculosis, for measles, right? Taking those case data, moving it to the public health agency, we pivoted to start moving COVID data because COVID was now in Indiana. And so tests were going to start being run. Those tests needed, our LOINC team at Regenstrief was creating LOINC codes, but we wanted those LOINC codes to be implemented within the Indiana Health Information Exchange. So we worked with them to begin doing that process and moving the data from the healthcare system on COVID to the public health department, so the public health agencies would know about all the cases that were in the community. And of course, on top of that platform, then the Indiana State Department of Health and other agencies can develop their dashboards, the information that they need to share with the public about what's happening with COVID-19 in the community. And so we began this process, which we're used to, of integrating data and pushing it, right, sharing it with others, and then using it for a number of things. Also, we were engaged to say, especially at the School of Public Health, to say, what's going to happen next? Like, what model should we be looking at? What's your forecast? Like, where is this disease headed? And so we know from prior research that there's different compartments that people can fit into, right? Initially, everyone is susceptible to a novel disease like COVID-19. Some people are going to become infected with it. Some people are going to end up in the hospital from it, and some of them are going to end up in critical care and then unfortunately pass away from the disease. And so we started to begin building models and forecasts for what things might look like in Indiana and how the population might be stratified across these different states that they could be in at any given time. So we actually found a model that the CDC had created with preparedness work a number of years ago called Flu Surge for pandemic influenza. And then we were able to basically kind of get to the guts of it and reorganize it for COVID-19. So for example, we ripped out all the code that was related to vaccination for flu because no one was at that time being vaccinated against COVID-19. And then we looked at the available evidence from China, from Italy, what was coming out of New York at the time, the best available evidence to put in model parameters for what we thought would be, for example, the average length of stay in an ICU for someone with COVID-19. And we worked with our health system partners to kind of tweak this as we built it, but we began sort of building models and sharing them with the health system and public health leaders so they would understand what the potential impact would be here in Indiana. We built models for the state, and we actually were invited to go and present those models to the governor's team at the State House. So right as basically the rest of the city was shut down, we were convening with the leadership and walking them through these models and our assumptions around them about what the impact could be. And every time you're doing modeling, there's sort of a maximum, worst case scenario, best case scenario, and most likely scenario. And we walk them through that. And the bottom line of what we were telling the leaders is that as of mid-March, 2020, the state did not have enough critical care beds and ventilators, right, to support the projected number of patients who were going to come in. So that would be, the state needed to request those resources from the national stockpile. Our hospitals really needed to start preparing for, receiving these patients and triaging them. And this is what the scenario could look like. In response to that, I would say, the governor then, instituted a lockdown for the state, and everyone started working from home. Now we go to April, right, where we have been in lockdown for a couple of weeks. Everyone's trying to adjust to a new normal. And that's when we really started to kick things into high gear in the program. And at this Fairbanks school, we started doing work on our statewide prevalence study. So Nir talked about this a few weeks ago. I'm not going to go into a ton of details, except to say that it was part of the research that we started to engage in so that we could fundamentally understand data around prevalence and incidence of disease, which helps us do things like better model things going forward, feed downstream processes that I'll talk about in a moment. I also shamelessly borrowed the slide from Nir with his permission, because what that first study did in April of last year is that it allowed us to really understand, this part that's below the iceberg, what you can see from the surface of the water, right? The iceberg, most of it is under the water. And so we knew from all that work we were doing to bring in data to the state health department, so that they know about cases that were diagnosed initially by the state health department and CDC only. Eventually, all the hospital systems started to run labs. Lilly was running labs for the community and sharing that data. But those were the diagnosed cases. But there's all these people below the surface, right, who are asymptomatic or symptomatic but not tested, right? At that time, there was very limited testing resources available in the community, particularly in late March, and even in April, the state was still building its plan and those sites that you can now go to get tested. And CVS and the other retail places weren't doing testing at that time. We also were approached by the IU Vice President for Research, Fred Kate, to say, hey, would Regenstrief like to partner with an industry group to work on COVID stuff? And we said, sure, we would. So we started our engagement with Microsoft, particularly Microsoft News, in order to launch a mechanism by which we could gather data around individuals' perceptions, population perceptions of COVID-19 and population level behavior associated with COVID-19. So with the support of that team, we launched a survey. So when you were browsing around Microsoft News, you would be asked to take a moment to complete a survey around COVID-19 for the Regenstrief Institute. And so this really allowed us to begin collecting data towards the end of April on perceptions. We're still collecting data right now through that platform. Then in May of 2020, we had the Back on Track plan, right? We had a plan now because case rates were starting to come down. We were going to try to get, back on track in terms of our economy and start to reopen things. So many of you remember this chart, right, which walked us through 5 stages that the governor outlined for how Indiana would get back by July 4th to kind of its fully reopened stage. Of course, it ended up being a little bit later than the original plan, but there was this staged approach to reopening. So we began to start thinking, well, okay, if the state's going to slowly begin to reopen, what additional data do we need to be collecting on the population? That's where with IPIC, the Indiana Pandemic Information Collaborative, I was co-chairing the subgroup on modeling and surveillance, essentially. And we were having a lot of discussion around what we would measure. And we said we should come up with a way to measure activities like wearing masks. So we came up with a study protocol. We sent trainees and others into the field. We dubbed citizen scientists to go out and collect information. We had a red cap survey that we used that they could fill out with a bunch of check marks around whether people were wearing the mask correctly, incorrectly, or not at all, as they were going to Kroger and Lowe's and other places. And we had, we developed some tools to train them, but it was kind of rudimentary. We kind of threw it together, an electronic, if you will, equivalent of a clipboard with some check boxes. This, of course, in talking with Dr. Imby through the process, and as we kind of did this actual field work, it got translated into now what we have as mask count, right? The app where you can now go and it has been released and is out there publicly available. People can now just swipe to indicate whether someone's wearing the mask partially, not at all, or fully, and allowed us to collect then data both initially last summer with the kind of rudimentary app, now with an actual app that you can use on your mobile device very easily to collect these data. So by kind of late summer, early fall, we had this growing array of data around cases and hospitalizations and ED visits and people who were dying from COVID-19. We had a lot of information on comorbidities and other health conditions related to those cases. We also had all this data that we were collecting around perception and behavior. And so the question became, over time, we had to build mechanisms, not only for managing these data, but also to operationalize them, right? All along, we weren't just collecting data for the sake of collecting data or collecting data, for some study we might publish a year or two away. I mean, rapidly, people were collecting data and sharing that through publications, through preprints, through all sorts of mechanisms last year. And so we needed to, in real time, share what we knew with public health and with our health system leaders.
Brian, quick question from the audience.
Yes.
So Helen is asking, I'm curious about population profiling with racial, ethnicity, and chronic disease variables in the modeling. Was that something you saw early on or later, disparity in COVID infections and so on?
Definitely saw a disparity in infections and stuff, and I'm going to touch on that. Not so much, we weren't necessarily concerned about profiling so much. We were concerned that data were released in a way that would prevent, someone from individually being identified. But, public health was very interested in tracking, racial and ethnic minority populations from the very beginning, and they wanted better data to do that because they were concerned about those. They're always concerned about those populations, but it became very clear early on that minority populations were overburdened with this disease, and so public health really wanted to track it. Many of you are familiar with the Regenstrief dashboard, which is one of the products that came out from our work. Here, I wanted though to share, this is an early version of the Regenstrief dashboard. So we love the way the dashboard looks now. It's much, much cleaner. But when we put something together, Connor McAndrews just amazing to build this and refine it and rebuild it and refine it some more over time. But very early on, you can see even here from the very, version 1, there are subpopulations we wanted to monitor, age groups, race, comorbidities, gender, trying to follow those trends. Generally in public health, we always think about, gender, race, and sex, or I'm sorry, age. Those are kind of 3 things we always kind of dial in on right away. And so those became very important subpopulations to follow and in our work. Now, once we have a platform that is collecting these data, managing it, making it available to, originally the dashboard was available to local public health authorities and the state health department only, right? It was a private dashboard. We still have a private version of the dashboard where those entities can go and look at detailed data detailed data all the way down to the level of an N of 1, right? Because they have the authority to do that. On the public side, we put some precautions around it, so you can't dig down and find, someone who is in the minority in a small town or small section of the city. But we still now make a lot of the data public. But it was available early on for public health. And once you have data flowing in, then you can do things like, make inferences in trend and forecast. So Sean Granis and others led the development of a trend portion of the public dashboard in particular that allows us to monitor both subpopulations as well as at district and county levels about what's happening. And these are looked at by health system leaders. I hear all the time that they look at this information and they use it. The state health department finds the information very valuable. And so through this whole process, we were constantly refining and getting feedback. But now we're trending data because people are interested in what are the trends and where are we headed with this disease. The other thing we can do with the data once we had it in our platform is we could validate some of the initial models that we came up with. So in this slide, the orange bars are the model that we came up with at the School of Public Health to show where COVID was likely to be in terms of hospitalizations in the state of Indiana. The dark blue line, the horizontal line there, is data from the IMPC on actual hospitalizations. And then some of the other bars, the light blue bar and the yellow bar, are from the Institute for Health Metrics and Evaluation. That's the group out of Seattle that has models for the whole country in different states. We were tracking their models and what they were coming out with. And so we can compare to sort of see, were we on track? We're indeed on track to meet the model that we initially came up with at the School of Public Health, but the lockdown was put into place during that second week. And so a couple weeks later, we really started to bend the curve and head in the right direction. Thanks to the lockdown, even though it was a pain in the rear, it really helped get the disease under control, and our case rates and our hospitalizations began to fall dramatically after that point. We also took all these data and we began putting together weekly briefings using our data assets for the State Department of Health. They were obviously getting a lot of the data directly that they can put into their systems, but it was helpful to them to have some reports being generated. So we generated reports and sent that to the health department. We generated reports and sent it to our high population county health departments in the state so that they could track what was going on in their jurisdiction. We put together reports that were sent out to the leaders of our health systems because they wanted to know what was happening in their community. Yes, there was the dashboard. They could go to that and look at it, but they wanted some kind of standard reports to look at and that they could share internally with their leadership team. So we put those together and we're still sending those out every single week. I just finished them up right before the call and sent them out. We have partners, the medical response team at the university, the Indianapolis Coalition for Patient Safety, Indiana Hospital Association, Rural Hospital Association, all of those groups who work with health systems in this response. They also wanted insight on what was happening around the state. And so we put together these reports that get sent out, and I am told they're used very frequently and people enjoy them. And that's exactly what we want, is we want to meet our partners' needs and give them the information and data they desire. Some examples from these reports include estimating prevalence in different regions. We can take the data that we gathered from our statewide prevalence study, and then we can use it to make inferences about what true prevalence is in different populations. So we came up with early on that about only 1 out of every 10 or 11 cases that were out of every 1 diagnosed case, there were 10 to 11 cases in the community. So CDC said, okay, it's 1 in 10, right? That became a headline number. And so we can apply that then to making inferences. Now we've refined that through the help with Justin Blackburn and others at the School of Public Health, but Nir and his team are still kind of refining it and using the methods that we developed in the prevalence study to help us understand where prevalence is, or a cumulative sort of prevalence over time is for the population. Because as we think about what the impact of COVID is going to be in the future, we need to understand where we're at, prevalence-wise, as well as our vaccination rate, right? Those two data points can help us then infer what the trajectory of the disease is likely to be going forward. We can also do things like in these reports is track specific age groups. So we can look at an age group like people 60 to 69 years of age. We know when they became eligible for the vaccine, and we can track community level cases before and after that date. So you can see that before 60-year-olds were eligible for the vaccine, cases were actually falling. We had a huge surge in the fall, then cases began to come down in early 2021. As vaccinations began to be adopted by this age group, cases have remained very low and flat in this age group. So I don't think from these data we would conclude that vaccines like bent the curve for this age group, but I think they've certainly helped keep this age group protected going forward, which is exactly what you want. You want to prevent reinfection or future infections by giving people the vaccine. We also, again, to Helen's question around disparities, measured disparities and began to look at it in different phases. So over time, so here in this graph, phase 1 is that early lockdown, March, April of 2020. Phase 2 is the summertime as Indiana began to be reopened. And phase 3 is after we fully reopened in the fall through December 31st, 2020. You can see that over time, the per capita hospitalizations for different racial groups increase. So the general trend was increasing through the 3 phases, but certain groups were hit harder than others, right? So even though whites, for example, begin to catch up with other racial groups during that 3rd phase, they didn't, you know, it wasn't worse in that group during phase 3 or overall, right? The group that was hit the hardest was our African American community. As vaccines began to roll out at the end of the year, we pivoted and started to support vaccination efforts through data. In Indiana, the state health department decided to use CHIRP, which is our statewide immunization registry, as the source of truth, right? That's where all vaccination data goes. That then is made available to others, but that's the source of truth, right? Even before the pandemic, that system had data on most people in the state of Indiana. We worked with IHI, right, to interface that data from CHIRP into the exchange so that clinicians could access information on who's been vaccinated. Then at Regenstrief, we could create downstream, right, products and information around vaccinations. So we're working now on adapting our dashboard to represent population level vaccine data, right? That's a work in progress right now. We are also, with the support, Dr. Sean Granis is kind of leading our team, but we have a team here that's focused on doing essentially post-marketing surveillance of the COVID-19 vaccines, looking at vaccine efficacy. For example, when there was news that, for example, the Johnson & Johnson vaccine could potentially cause a rare, health condition, Amy Hancock from our data services team queried the IMPC, and we found that there were, not many cases in Indiana. So just like everywhere else, we found that the risk was about 1 in a million for developing that. And those cases were even treated in the outpatient setting and weren't even hospitalized. So, having these data available, linked and integrated allows us to support the activities of public health and our health system partners. We've created a number of IRB studies and are actively working on a number of studies at any one time. And Ashley, probably if I ask her to create one more, is going to, reach through Zoom and strangle me because, we constantly being inundated with requests to do more and support more. And the team has really stepped up to do that. But, there's a limit, I think, to that. But we're doing a lot of very interesting things and have had the opportunity to engage in our partners in doing these interesting studies and evaluations. We have translated what we have found. That's very important. Initially, putting things out as preprints, eventually getting accepted into journals and publishing them. But we've got papers out around the infrastructure for our dashboarding work. The survey work we've done with Microsoft has been accepted and is being copy edited and hopefully will be out soon. The work we've done over at the School of Public Health with the prevalence study, including understanding symptomology of COVID-19, has been published and is out there as well. So that's an important part of being an academic, but most of the information is fed to the state health department, local health department leaders, health system leaders, well in advance of these publications. They're getting our weekly reports and these data almost in real time, because that is our first and foremost priority. Secondarily, we definitely want to share what's happening in the state of Indiana with others. So where are we headed? This is work that I did with some colleagues from IBM to look at, in a pandemic, we're often focused on public health, particularly in our program, but, there are multiple sectors that have been impacted by COVID and are needed to move from from response to recovery. And of course, eventually, it's important that we learn from COVID and make better preparations in our public health infrastructure for the future. So I just wanted to point out that where we're really headed next is into a recovery phase, I should say. We're actively in response to COVID-19, but I think as we move through 2021, it's really about recovery. So our program goals in this recovery phase are to continue to obtain funding for our research and training. Titus mentioned the T15 program. We want to expand training opportunities beyond that program. We also want to, and have been, engaged in grant submissions around long-term effects from COVID. We don't know what those are. We're trying to study those now as we head into recovery, and recovery itself related to populations and subpopulations. That is going to be challenging for many people, and we will be engaged in studies to examine that as it happens and hopefully inform the process as well. We want to implement systems and tools into public health and population health practice. So again, systems for public health reporting, disease surveillance. There's going to be a lot of activity around that from CDC. We are standing by and ready and willing to engage in that work, but also care coordination and wraparound services, all the work that Josh and Saranga and Nir and others have been engaged in around upstroms and wraparound services. That's part of our program, and we support the activities with our health system partners in that way as well. And we want to continue to create and sustain population health data resources. So disease registries beyond COVID, there's work at Regenstrief is well underway for COVID registry. We're thinking beyond that, as well as the broader infrastructure that we need for population health long term. So some specific projects we are engaging in or have proposed recently is around disease registries for chronic disease in particular. So as we enter recovery phase, it will be important to continue to focus on chronic disease because those were major health challenges before the pandemic, and they're going to be major health challenges going forward. So traumatic brain injury, hypertension, diabetes continue to be really important, particularly in the state of Indiana. Combating public health crises like the opioid crisis, which only was exacerbated by COVID-19, certainly did not dramatically improve over the last 15 months. Mental health is something that is increasingly being recognized as important for our recovery phase. So we have some projects proposed and recognize the need to continue our work to integrate behavioral health, clinical health, and public health in this recovery process. And of course, modernizing the public health infrastructure for the future. COVID exposed a number of weaknesses in our public health system, and we want to help fix those going forward and work with our partners to strengthen our infrastructure so we are prepared for the next pandemic or the next major health crisis that emerges. So a few reflections on COVID. I think one of the things that is is evident, particularly from this pandemic, is that we have population health data everywhere. You know, multiple branches of the government are collecting it, health systems are collecting it, individual researchers are collecting it, programs are collecting it, community-based organizations are collecting it, but it's really hard to have them available when you need them, integrated, right, the way you want them to be integrated, and in a format that you need in order to respond. So that continues, I think, to be something that for us to work on as we think about our infrastructure for the future. Population approaches do support decision-making. You know, we've been able to, I think, inform a lot of population level decisions, and that's exciting, and we want to continue to do that going forward. And it does work. It takes a lot of effort, but it does work. And health system leaders and public health leaders are interested in data-based, data-informed decisions. I'm also, again, continue to be impressed by our team. Many people working around the clock over the last 12 to 15 months. Yet we recognize that we need more people because we, you know, as we think about the onslaught of recovery opportunities coming down the pipe, we need more people on the bench to respond to those type of opportunities. I also just want to close by recognizing that this summer, it will be 20 years that I will have been at the Regenstrief Institute and 10 years that I will have been at IUPUI as faculty. So it's actually 10 years ago this week that I finished my PhD at IUPUI. And so it's been quite a ride, but the last 15 months have been a real saga. Before that, though, was also very busy. But, you know, I wanted to share, right? This is one of the earliest photos that I could find, but Regenstrief has always been just a great place to work with amazing colleagues like John. I think you might be the only one who's still here from this photo besides myself, but just some great colleagues that we've had a lot of really good working relationships and fun times together. Many of you remember Clem. This is Julie McGowan, who's the whole reason why I got my PhD, was Julie nudging me and pushing me to get it and work on it. Titus, of course, as part of our public health informatics program. We've had a lot of fun on IU Day with photos and continue to have a great relationship. Our trainees are just amazing. If you have not met them or engaged in project with them, I definitely encourage you to do so. They are fantastic scholars and they are the future leaders of this field. And then of course, everything comes back to Sam. So just a wonderful place, and I've appreciated all of the teamwork and coordination over the years. Also, I want to recognize this is graduation week. Graduation is a little bit different this year, right? No pomp and circumstance with lots of people up on the stage. There's some of that happening for graduates only. Here's Clem getting his honorary degree 10 years ago. But we usually, you know, I do want to say, if you're graduating, take that moment, enjoy it, recognize it, even if it's a little bit different than normal. We would all love to have a school ceremony and be with you, and we'll look forward to doing that next year. And so a toast to all, I'll get my water cup, to all graduates, congratulations. This is, I've been a fan of Thoreau for many years, and I continuously, as I reflected on these 2 decades and the work we've done over the last 15 months, I think one could say that we as a program have definitely worked hard to suck all the marrow out of life, all the COVID data we possibly could, and make it available to people. And so we will continue to strive to do so going forward. So thank you to the whole team, the whole program. You've all stepped up this year, and I really appreciate it. And with that, I think we have about 15 minutes or so for questions.
Thank you, Brian. This was a great talk, a wonderful overview of the COVID-19 story in Indiana. It reminded me a little bit of pieces in the Atlantic or New Yorker that chronicled the epidemic. But of course, this story was really personal we've lived it, we've seen it, we've participated in it, and thank you for your leadership in that area. I also wanted to recognize something that may be obvious to some people, but not to others. I think your story and your slides really embodied our journey towards one Regenstrief. I don't remember many presentations at what used to be the WIPs where so many different projects suddenly ended up on the presenter slides. You've referenced obviously the School of Public Health, our colleagues there, our work with IHI, with ISDH, with other people within the Institute. So it was really great to see. It shows some of the power that we as an institute have to affect some really big things. And I have to say, I think I speak for everybody when I say it was sad that it took something of the scale and impact of COVID-19 to remind us of a lot of the good work that we could do together. And I'm happy that quite a few of our future leaders and many of our training program trainees are here, that they actually could see in your story kind of what the vision can be for Regenstrief and for them. So thank you very much for that. With that, we'll go to the first question. And if you want to alert me in the chat to your question, we can actually unmute people. So Paul, if you get ready to unmute yourself, that would be great, because I'm going to let you ask your question yourself, because that's somewhat more efficient. So we'll go to Paul, and then whoever else wants to ask a question, just put it in the chat. I want to talk next, and then I will call on you. Paul.
Yeah, thank you, Brian. That was illuminating. I guess this overall work seems like an exemplar instance of a learning health system. And, you know, the public health and learning health system seem to be combining. And for example, I looked up some of the features. There's an engaged, empowered public and patients. Your mass count's a perfect example of empowering the patients. The dashboard certainly empowered. The direct feeds to ISDH, the data infrastructure, especially the agility, the real-time access, the rapid data feedback that led to real decisions such as the lockdown, and informed how we could keep it under control. I guess going forward, I just wondered, how can the functionality approaches, the effective approaches sort of used for COVID be leveraged for purposes of Regenstrief's overarching plans for learning health system strategies, which is going to be one of the 4 prongs of future strategic direction.
Yeah, good question, Paul. Thanks for that. Yeah, well, that's probably a question for both Titus and myself. So as Titus is leading our LHS work, you know, we often have conversations around how the programs, you know, global health, public health, LHS, dental, you know, how do these programs kind of work together? So I think it's a very good question. I think, you know, certainly one of the things we're trying to do right now with the Indiana Pandemic Information Collaborative is think about how that pivots to the next thing, right? Because it's moving away from response, and we, you know, are we going to focus it on the recovery stuff? Are we going to pivot it to something, you know, broader like social determinants? Are we going to, you know, pivot it in a different direction? So that's one set of activities that we're currently kind of thinking through. We don't kind of have finalized, but I think that's one direction, is to say, you know, we really enjoyed working together, right, between the health systems and public health and the different components of Regenstrief. And I mean, Titus, you know, within the School of Public Health, our kind of, you know, response team was made up of people from every department, and it was just wonderful to have that interdisciplinary response to these things. And that's really what you need. So I think that we are trying to figure out right now. I think the question you ask is exactly the one we're asking, which is how do we take this and pivot it to address diabetes in the state of Indiana, or how do we take it and use it to address, you know, smoking cessation or whatever, you know, those high priority population health questions are. How do we pivot to that, and how do we take this infrastructure that exists now? I mean, we have hospitals that are sharing data for COVID that have never been part of the IMPC. How can we build upon our success from COVID, keep them in the fold, right? And work with them to engage in some of these other areas that we want to work on and support learning around other conditions and diseases.
Thank you.
Yeah, good question. You know, leave it up to Paul to ask a question that actually requires another Grand Rounds presentation just to answer. But I think you're way on point, and Brian's response was right on the money. I would probably add that one of the things that is important in this is, as Brian's presentation showed, there was a lot of the competence around data, algorithms, and visualization that made a difference in his work. And that is also the area, the focal areas around which we've refocused the Learning Health Initiative, which, as everybody in the room knows, is not just for one hospital system, it's not just with IU Health. The intent is really to do things for all of Indiana and hopefully at some point beyond. And so I think this one, the synergism that has really good results, coupled with the real world relevance and application, it's probably the two things that we can really hit on that will help make all of our efforts progress. All righty, Sean is unmuted, so I'm sure Sean wants to talk. Go ahead, Sean.
Sure, thanks. Great presentation, Brian. Either yesterday or today, the World Health Organization announced that they want to develop an international disease surveillance system. What role do you think Regenstrief and IU could play in that process?
Yeah, I think we definitely, well, first and foremost, I think we can play a consultative role in the development of that. I mean, we've been, different parts of Regenstrief have been engaged with ministries and folks both in and out of the US, CDC included, for years on thinking about integrated surveillance. So I think that we definitely could play a consultative role there. I think we also have the opportunity probably to, you know, kind of demonstrate how integrated disease surveillance could work and probably be, you know, a pilot site if that's going to be a phase of their activity. But yeah, I think there's a lot of activity at the international level to revisit the international health regulations, come up with a new version of that, and really make integrated surveillance happen. They've been talking about it at the WHO for a while. And I think now with COVID, because of COVID, there's a real interest in putting some teeth behind some of it to make it happen, because you know, some parts of the world can get there. Other parts of the world are going to need a lot of support to get there. And so we can help advise on what the strategy should be, but also from our global health informatics program, we know what the challenges are from our work there and can help identify areas where WHO would need to work with member states to strengthen the public health infrastructure to even get to a place where some countries could have integrated health surveillance.
Great. Helen has another question for you, Brian.
Hi, Brian. Thank you for this great presentation. I always love to learn more about COVID. So my question is, I'm curious about geocoding in a data set. So is there potential for one to know about the social activity pattern with contact tracing? In particular, meaning like, could I know, like, you know, or there's a model you can know that there's a certain location, going to grocery at this location, or if I attend the school, that I'm more likely or have higher risk of getting COVID infection. So I did not know how detailed, if the data included that potential possibility to answer the question.
Yeah, so on the one hand, we actually have a really nice process for geocoding data. We have a great partner in the Polis Center, which is another research center at IUPUI that we work with. And so data from the IMPC flow into the Polis Center for geocoding, so that in the patient's record, we have geospatial data about where they live. Now, we know essentially, though, what you're asking, though, is a step beyond kind of what we have today. So we don't know all the places where the patient went before they got COVID. We know where their home address is, and we know that they were hospitalized. So we're able to look at clusters of where infections are happening in terms of people's residents. And we have clusters where, for hospitalizations or deaths, for example. But what we don't have is we don't know necessarily where people work. So we can't look at work versus home versus play. And so we don't have some of those components in the repository today. But that's definitely some of the things that public health would love to have. Public health also has that in some other data sets. There was a lot of, we have been looking at like the Google mobility data, for example, which tells you at a population level, people's patterns of behavior change. Doesn't allow you to track an individual person. From contact tracing data, though, you do know kind of their risk profile. And so we actually have one of our trainees leave and go work for the state health department to do that analysis. So there's activity like that happening in public health to identify those COVID hotspots, if you will, although contact tracing data has a lot of limitations and there are a lot of people who refuse to participate in it. But even with those limitations, that's how some of the data have been used to identify, for example, that most disease transmission occurs in small sort of indoor gatherings rather than, some other types of activities, for example. And that's definitely knowledge that we want to glean from those data.
Thanks, Brian. We have time for one more question. And while you guys are ready to getting ready to ask it. So Helen, there is actually a local startup that has done what you suggest, which is develop a local risk index. I actually used to work for them part-time. And what they did is they used aggregate lab results, feed data to predict COVID hotspots. And their CEO actually presented about a year ago with our IPIC group. And they claimed at the time that they could tell where things were going to get bad about 2 weeks before the infections, before it was visible in the hospital. So I think your question is right on the mark. Okay, 2 minutes to go. Any other questions?
Gerardo, did you have a question? Okay. I saw your video come on, so I thought you were maybe trying to get in line to ask a question.
No, I'm not. Sorry about that. There's a strange sign there. I don't know what that is. Thanks.
Yeah, no worries.
All righty, going once, going twice, going 3 times. Thank you very much, Brian, again, for a great talk. Again, this is wonderful, and keep up the good work and try to get some sleep once in a while, okay?
Maybe this summer. We'll try.
Right. Inverse hibernation.
Good idea.
See you guys.
Thanks, everyone.
See you. Bye.